Hi, and welcome back to part 2 of session 1 for the history of healing. So we're going to start pick up where we left off, looking at traditional medicine and complementary medicine in a worldwide basis, more in the present today, or close to today anyway. So in 2001, the World Health Organization stated that the most commonly reported reasons for using traditional and complementary or alternative medicine are that it's more affordable, it more closely corresponds to the patient's ideology, and it's less paternalistic than allopathic medicine. So this reckons back to some of the things that I was talking about in the first part of our lecture, where I talked about what people have access to in a socioeconomic perspective, how much they can afford, what's available in their social or cultural surroundings, and also the patient's ideology. What are the patient's beliefs? Are there religious beliefs or philosophical beliefs or other types of beliefs that would cause a patient to gravitate more towards complementary or traditional medicine, such as liking the holism that's practiced there generally. And I want to talk about this word paternalistic. Paternalistic is a term that means a relationship that sets up the doctor as an authority or the practitioner as an authority over the patient. And so in a conventional medical sense, oftentimes the relationship is a paternalistic relationship where the patient is looking to the doctor as a source of authority, as an authority figure in some way, to tell them what's best for them. And traditional medicines tend to have less of that kind of relationship going on. They tend to be more of a partnership between the practitioner and the patient or client will tend to have a greater level of responsibility, for example, towards their own type of daily behaviors and diet and things like that. So it's less paternalistic, and that's one of the reasons why traditional medicine or complementary medicine is more accessed worldwide. So going on with this statement, regardless of why an individual uses it, traditional and complementary or alternative medicine provides an important healthcare service to persons both with and without geographic or financial access to allopathic medicine. So they're using allopathic medicine here to mean conventional medicine, chemical and surgical medicine, so prescription drugs and surgery, that type of thing. So there's a large range of practitioners worldwide that would fall under the category of traditional or complementary or alternative or holistic practitioners. We have traditional or indigenous practitioners. We'll use the word shaman a fair amount this semester to describe some of those folks, and we'll define that more when we come to it. But the traditional or indigenous healers tend to be those who come directly out of the cultures that they and practice within the cultures that are their foundation. There are practitioners who are informally educated, and informal education can be anything from a lower level course that may not be rigorous in terms of its scientific basis or its having supervised practice within it, or it can be even being educated over the internet. So that's informal is a very big category there. We have vocationally trained or apprenticed practitioners worldwide, and vocational training has lots of different levels of quality and rigor in different places around the world. We have online or correspondence trained practitioners, and that's true even in contemporary Western society. And then we have degree trained with clinical supervision, and clinical supervision is part of the education, and that's the type of courses that we provide at Endeavor for clinical courses, not for the complementary medicine degree. So you can see that there's a very, very wide variety, and you're going to get not only different levels of education, but different levels of immersion in a culture. If you're learning something cultural and you're doing it in a modern westernized classroom, you're certainly going to have a different experience of that culture than if you, say, went and apprenticed to a traditional healer. So this isn't placing one level of training above another necessarily. It's just to let y'all know that there are multiple levels. And this is not an exhaustive list. It's just meant to demonstrate that worldwide, across lots of different cultures and lots of socioeconomic settings, there are practitioners of different types of traditional or natural medicines who have many different levels or types of training. In the westernized world, or in the industrialized world, degree level training is obviously becoming the new minimum standard, but it's important to recognize that that's not applied across all jurisdictions in the industrialized world. It's also not applied to all therapies or all regulatory frameworks at this point in time. And so as we travel through history, we'll see that in the past, this was also true of people who were considered conventional doctors of the time right up until the 20th century, when conventional medicine began to first be formally regulated. So we'll see that medical doctors, or people that were considered to be physicians historically, had a wide variety of different levels of training as well. Some of them went to university training. Some of them were trained by being apprenticed to a local doctor. Some of them were self-trained in some ways. And so this is not a new thing that we have these days. But along with this, we also have to mention the increasing levels of research that are now being conducted in complementary medicine. And that's contributing to the professionalization of various disciplines. And the trajectory that that's on at this point in time is to require a higher level or a degree level of training within the industrialized world if a person is going to practice as a complementary medicine practitioner, especially for the ingestible therapies or for regulated professions such as acupuncture. So as conventional medicine, the education and approach to research have been standardized and regulated in the first half of the 20th century and on into the present. That's continuing. And complementary medicines are on a similar trajectory to increase the legitimacy and standards and safety coming into the 21st century. So we'll see this as we travel through the history of what we'll call regular medicine, that it was a long process over centuries that it took medicine to become truly a profession, to move out of the realm of philosophy and the study of science and into being a profession on its own. And certainly there are pros and cons for complementary medicines to be following on that similar trajectory and to become more regulated and more professionally recognized. Some of the pros that we see in the increased level of regulation of complementary medicines or the increased professionalization of our disciplines are improved and increased public understanding and trust of our professions, and the prevention of the practice of our disciplines by untrained or unqualified practitioners. We also see improved educational standards and consistency and increased legitimacy of our professions, as well as increased cohesion of our professional bodies. And in Australia, this is still something that's in process. And if you look at the profession of acupuncture, it's already a regulated profession now, a registered profession, and it has progressed somewhat further than some of our other complementary or alternative health professions, which are perhaps pursuing a similar path. Some of the downsides of increasing professionalization or increasing regulation of complementary medicines. In some instances, that can result in devaluing the traditional aspects of a discipline because those might be seen in a modern framework to be more non-scientific. Regulation can oftentimes put pressure on to use a more narrow definition of what's considered legitimate evidence of efficacy. And we're going to talk about types of evidence just here shortly. I think that starts on the next slide. There's also a potential for moving away from individualized approaches to holistic medicine and moving towards systems of protocols, which means for a certain illness, if you say you're a naturopath for a certain illness, you would need to prescribe this drug, this herb or this nutrient as a matter of habit, as opposed to taking a more individualized approach to the patient. There's a bit of risk in a regulatory framework of moving in that direction. And there's also a pressure with regulation to perhaps move more towards or in alignment with what's considered mainstream. So you lose perhaps, or you have a danger of losing the full breadth of practice of a traditional nature or its core philosophies. So those are all things that our professions should be interested in, keeping our finger on the pulse as we move towards more regulation and more professionalization of our disciplines. So what is evidence-based medicine? We hear this term talked of a lot. And in moving towards a greater legitimacy in the mainstream culture of complementary medicines, the juggernaut of that movement in the eyes of the conventional system is the concept of evidence-based medicine. And some individuals and groups within the conventional system or who work alongside the conventional system may make some broad and sweeping claims that complementary medicines have no evidence of their safety or efficacy. And certainly we've seen this recently in the realm of homeopathy. And other complementary disciplines are also are painted with quite a broad brush in sometimes making this statement. So setting aside the fact that there are clearly large volumes of research evidence behind the complementary therapies, and each of the complementary therapies have our own evidence base that we can call on, and some of those overlap. Also sort of setting aside the fact that modern degrees in complementary medicine are health science-based degrees, and so obviously rely upon established biosciences in order to provide the foundation for what we do. There is this question about what would be considered to be valid evidence when we have statements from outside of our professions saying that there is no evidence base for what we do. So what is considered valid evidence? And this is an important issue that most or all of you will come across in your studies and also in your later careers. So that's the reason why we like to address it up front, to provide a foundation for you to discuss this amongst yourselves going forward, and to address any challenges you might get from those around you in terms of what you've chosen as a career. So before we dive in, we'll just talk a bit more about what we would consider as a valid evidence base. And throughout history, including mainstream medicine throughout history or conventional medicine throughout history, the conventional scientific methodologies sometimes yielded erroneous information or incomplete information upon which medical practice was based. And so I think that we always have to be sure that we're paying attention to the fact that because something has been established scientifically doesn't always make it infallible in terms of being the absolute truth, because I don't think that we've established anything as absolute truth at this point in time. Maybe some things. We've established that we have bones, we have muscles, etc. And then there's a large body of evidence that is orally handed down through traditional systems of folk medicines that have stood the test of time and that have never been documented in scientific studies at all. So we've got this, this whole gamut of what might be considered evidence. So this is a definition on this slide, or this is the first part of a definition on this slide from 1996 of what is evidence-based medicine from Sackett. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So you notice right away this has two parts. Integrating individual clinical expertise, that means expertise that the doctor or the practitioner has developed within themselves from their own experience. Perhaps they learned something from somebody orally, they have tried it and they've used it over time and it has worked, so they keep using it. Integrating that with the best available external clinical evidence from systematic research. So research is or one side of the coin. By individual clinical expertise, we mean the proficiency and judgment that individual clinicians acquire through clinical experience and clinical practice. So this definition of evidence-based medicine gives the latitude to the practitioner to amass their own body of evidence based upon what they have found works. And most of the time that is based upon having learned that from somewhere else or someone else who imparted that information as something that works. So the next part of this definition, genuine evidence-based practice actually presupposes an interpretive paradigm in which the patient experiences illness in a unique and contextual way. So this is automatically making the interpretation of evidence dependent in some ways on the patient's unique experience of their illness and their unique experience of whatever healing modalities they have, whether that's a drug or surgery or a herb or a massage or whatever it is. So furthermore, it is only within such an interpretive paradigm that a clinician can meaningfully draw on all aspects of evidence, his or her own case-based experience, the patient's individual and cultural perspectives, and the results of rigorous clinical research trials and observational studies to reach an integrated clinical judgment. So this is defining evidence-based medicine or evidence-based practice as integrating all the different realms of knowledge that we have, and that includes the patient's subjective beliefs, their cultural and philosophical beliefs, and the things that they want to interact with in medicine as well, in order to put together and integrate a really holistic viewpoint on both diagnosing and treating a patient. So this is really important, and this is also really aligned with the way that complementary medicines or holistic medicines in general will approach diagnosis and treatment of a patient. And then here's another definition of evidence-based medicine. This is from a different study by Greenhall. The truths established by the empirical observation of populations in randomized trials and cohort studies cannot be mechanistically applied to individual patients whose behavior is irremediably contextual and idiosyncratic, or episodes of illness. So this is kind of a long sentence, and it's got a lot of unfamiliar words in it. So I'll just break this down. Basically, this says that if you're just using randomized controlled trial, which is the gold standard of scientific or medical research, you can't just apply that mechanistically to an individual person, because their different bodies behave different ways in response to different medicines, for example, and people are different. Our biochemistry is different. The way that we respond to even the personality of a practitioner can be different, and can make a difference to how we would respond to a medicine. So it's about creating a context. And it's really important that we acknowledge these broad concepts of evidence-based practice. This is generally recognized by complementary healthcare practitioners and complementary disciplines. But generally, these definitions that I've just been through are not recognized by the conventional system. The conventional system has a bit of a different view on what evidence-based medicine means. And so we need to understand that what we might call dogmatic science has become an increasingly important part of our medical culture over time in a mainstream sense. And so throughout the development of history throughout this subject, we'll have a really great opportunity to see the different dynamics that science has gone through over time, and we'll see where that's arrived now in this more rigid idea of what is evidence. And we'll also get to see in the past, in history, times when there were medical philosophers or medical scientists who adhered really dogmatically to old theories, and they were ridiculed and ostracized if they didn't follow those dogmatic theories. And some of those dogmatic theories actually turned out to be false in the end. And so it's important for us to have that context, that there's a lot of human nature at play here. There's a lot of ego at play in medicine, and we'll see that throughout history. So we'll go through here and just talk about a few different models of evidence and what we have access to in this day and age. RCT means a randomized controlled trial, and that is the gold standard for conventional medical research at this point in time. So I'm going to break down that term, randomized controlled trial. That is basically taking a single intervention, so a single drug or a single type of surgery. Let's set aside surgery for now. Let's just talk about a drug or even a herb as an example, or a nutrient. Taking a single intervention against a single illness and taking people with that illness and randomly assigning them into either a group that will receive treatment or a group that will not receive treatment. So that's a randomized assignment. That is generally blinded so that the practitioner and the patient, neither one knows which group the patient is in, so you don't get the confounding by influence of that knowledge. The control part of the trial that means you have two groups. You have a control group and you have a treatment group. And a trial, obviously, is a trial. So that's what the gold standard for conventional medical research is in this day and age. And you will find out and learn a lot more about that when you get further on in your course, when you take Foundations of Critical Inquiry and learn more about how to interpret scientific studies. So the standard randomized controlled trial design has been acknowledged as having really limited utility in evaluating holistic medicines. And the reason for that is that holistic medicines use more individualized treatment planning. And we also use multiple treatment interventions at the same time with a patient. So if a patient comes in, say they have rheumatoid arthritis and they come in, we are going to give them a number of different treatment interventions perhaps at one visit, and where they're going to go in, use those together, and then they're going to come back and we're going to look at how much improvement they had. And if another person comes in a week later with rheumatoid arthritis, we might give them a different collection of treatments, and that's because we're looking at them in a very individualized way to assign treatments to them or to prescribe treatments to them that are more individually suited to their situation. We also have some aspects of our treatment in a holistic framework that are subjective, such as counseling. And so if we are working with a person on the level of not only body, but also mind and spirit and emotions, then we're going to be working with them with some things that are physical, like herbs or nutrients, and we're going to be working on other things that might have to do with talking through emotions with them and things like that. And so it's a difficult thing, if you think about how I just defined a randomized controlled trial, to be able to shoehorn what we do into that kind of design. And so for most complementary therapies, whole practice research is really the preferred way to go, which is looking at the practice holistically, not just us looking at the patient holistically, but evaluating what we do in a holistic way and in evaluating it in the way that we actually do it. And so we have to look at whether whole practice research will ever be considered as a valid evidence of efficacy by standard medical scientists or conventional medical scientists. And at this time, we do have a reason to feel optimistic about that, that appropriate and valid research models for holistic forms of medicine are really gaining legitimacy at this point in time and acceptance. And that's both inside and outside of the complementary medicine community. There's been increasing acknowledgement, for example, at the U.S. National Institutes of Health, of whole practice research designs and the fact that those fit what we do much better than the randomized controlled trial does. The other major discrepancy between conventional research and complementary medicine research relates to funding, and this is really important to keep in mind as well when you go forward in your course and you start looking into the kind of evidence that there might be behind what it is that we learn in our holistic therapies, our complementary therapies. Since the majority of complementary therapies are not patentable and the medicines are not covered by insurance or public health systems at this point in time, the industry really doesn't generate the same kind of funding base to support research as conventional medicine does. And so that's a really important contributor to the slower development of the research evidence-based in complementary medicine. So keep that in mind as you go forward and you start learning how to do research and accumulate evidence for what it is that you are taking off to do in your future career. So on the flip side, or maybe not the flip side because that makes it sound bifurcated in some way, we want to make sure that we are honoring the traditions of our historical systems and that we don't only look at what we've established as documented evidence, but we also give credit to the fact that these historical systems have very, very long histories. And in traditional historical systems, an evidence base was held generally by the healers of that tradition or that culture who passed that information down orally from person to person, and it wasn't necessarily documented. And they used empirical evidence with respect to traditional and time-tested techniques. So empirical evidence means basically if you use something and it works, then you try it again. And if it continues to work when you use it, then you develop a belief in the fact that that works, and that becomes one of your healing traditions. If you use it and it doesn't work, or if you use it and someone gets sicker from it, which is always a possibility when you're using things out in nature, because there are plants, obviously, that are poisonous, you observe what you learn from use. People also developed an empirical base of information about healing plants from watching animals as well. And the animals had been around for longer than the people, or perhaps had been imbibing some of the plants as a healing modality for longer than the people. And so observing animals was one source of empirical evidence as well. And so we have this question that sort of hovers over us today as we consider these traditions in their historical context and the way that that body of empirical evidence was developed. If a therapy or product hasn't been scientifically tested, and when I say scientifically, I mean through modern scientific analysis and trialing, can it still be effective? And I think that everybody has to come up with their own litmus test. All complementary practitioners need to come up with their own litmus test for determining what you believe in yourself in terms of the traditions that you might believe in or the scientific evidence that you believe in, because some of our scientific evidence is being overturned at this point in time. So it is an interesting atmosphere that we find ourselves in these days, where we have benefit of science and we have benefit of tradition, and we have to find our way through the middle ground of that so that we can take advantage of the best that both have to offer. And that's where the power is coming forward into the future. So with that, I will leave you as the end of our first session. Thank you for joining me for this session. And here's our references. Feel free to always dive further into any of the references that are there. Those links are there for your information. And we will pick up again in session 2 when you get ready to start that. Thank you.